C3IFT transport vasodilators. Introduction. Vasodilators treat a variety of conditions including high blood pressure. Vasodilators are medications that open or dilate blood vessels. They affect the muscles in the walls of the arteries and the veins, preventing the muscles from tightening and the walls from narrowing. As a result, blood flows more easily through the vessels. Your heart doesn't have to pump as hard, reducing blood pressure. Unlike beta blockers or calcium channel blockers, vasodilators work directly on the vessel walls. Use of vasodilators. Doctors prescribe vasodilators to prevent, treat, or improve symptoms in a variety of conditions such as high blood pressure during pregnancy or childbirth, such as preeclampsia or eclampsia, heart failure, and high blood pressure that affects the arteries in your lungs, which is pulmonary hypertension. Vasodilator side effects. Direct vasodilators are strong medications that generally are used only when other medications haven't controlled your blood pressure adequately. These medications have a number of side effects, some of which require taking other medications to counter them. Side effects include hypotension, tachycardia, heart palpitations, edema, nausea, vomiting, flushing, headache, and chest pain. C3 Interfacility Transport Protocol 3203 Vasodilator. This protocol is utilized when the patient is being treated with vasodilator for a reduction of preload or afterload. A. Perform interfacility transport assessment, procedure, patient care protocol 9204, and follow the proper protocol for medical management based on clinical presentation. B. Continue vasodilator as ordered by the sending physician. C. Monitor the patient for hypotension, bradycardia, or tachycardia. D. Titrate as needed in increments to maintain blood pressure within systolic and/or mean arterial pressure parameters as determined by the sending physician. B. Obtain vital signs every 5 minutes when titrating by vasodilator or if the patient's condition changes. C. For patients experiencing new onset or worsening of chest pain during an interfacility transport, reassess the patient's vital signs and obtain an additional 12-lead ECG. Titrate the vasodilator as ordered by the sending physician. E. If the patient blood pressure drops below 90 systolic with signs and symptoms of hypotension, such as tachycardia, mental status change, or change in the skin color, or if you have a drop more than 30 millimeters per mercury, temporarily stop the vasodilator and reassess the patient. Consider a 250 milliliter bolus of normal saline. If this doesn't work, or if the patient remains hypotensive, contact medical command physician.
When timely, precise blood pressure control is critical, Cardene IV, nicardipine hydrochloride, premixed injection is a proven steady, premixed ready agent for use in a variety of hypertensive emergencies. Cardene IV is indicated for the short-term treatment of hypertension when oral therapy is not feasible or not desirable. For prolonged control of blood pressure, transfer patients to oral medication as soon as their clinical condition permits. This program reviews the dosing and administration of Cardene IV and provides clinical evidence to support its use in appropriate patients. Cardene IV, nicardipine hydrochloride, is available in formulations of 40 milligrams in 200 milliliters and 20 milligrams in 200 milliliters in either sodium chloride or dextrose solutions, straight from your automated dispensing cabinet. The premixed ready formulation is immediately available for rapid intervention at the point of care and minimizes the risk of medication admixture errors. Cardene IV can be stored at room temperature in its original packaging for 24 months. Before administering Cardene IV, inspect the product for particulate matter and discoloration. Check for leaks by squeezing the bag firmly and ensure that the seal is intact. If leaks are found, discard the bag, as sterility may be impaired. Note that there is only one port on the bag. Do not combine Cardine IV with any product in the same intravenous line or premixed container. When connecting the administration set, fully insert the spike into the port and twist until the line is firmly attached. Cardine IV should be administered through large peripheral veins or central veins. Cardine IV does not contain soy or egg allergens. The most common adverse reactions, occurring in more than 3% of patients, are headache, nausea, vomiting, hypotension, and tachycardia. The starting dose for Cardine IV is 5 milligrams per hour in patients not receiving oral nicardipine. The infusion rate for this formulation, containing 40 milligrams of Cardine IV in 200 milliliters of normal saline, is 25 milliliters per hour. You can administer Cardine IV using rapid or gradual titration in increments of 2.5 milligrams per hour up to a maximum dose of 15 milligrams per hour. For rapid titration, increase the dose every 5 minutes. Once the desired blood pressure is achieved, decrease the infusion rate to 3 milligrams per hour. For gradual titration, increase the dose every 15 minutes until desired blood pressure is achieved. For either approach, adjust the infusion rate as needed to maintain the desired blood pressure. This chart shows dose to infusion rate conversion. You can find this information at cardineiv.com or within the full prescribing information. Monitor blood pressure and heart rate continually during infusion and avoid a too rapid or excessive blood pressure drop during treatment. Now, let's review some of the evidence that demonstrates how Cardine IV performs in clinical settings. Cardine IV begins to work within minutes. In a multi-center randomized study, 110 patients with hypertensive emergencies were treated with Cardine IV in the emergency department. Median initial systolic blood pressure was 212.5, and most of these patients had a history of hypertension. By 15 minutes, the mean percent change in systolic blood pressure from baseline was within target range. 92% of patients reached their target systolic blood pressure range within 30 minutes using the rapid titration schedule. In addition to a rapid onset of effect, Cardine IV also demonstrated smooth, predictable blood pressure control over 24 hours. In a study of hypertensive patients admitted through the emergency department for primary intracerebral hemorrhage, subarachnoid hemorrhage, or acute ischemic stroke, Cardine IV was initiated at a dose of 5 milligrams per hour and increased using gradual titration every 15 minutes by 2.5 milligrams per hour until target systolic blood pressure range was reached, or a maximum of 15 milligrams per hour was achieved. 89% of patients achieved their respective target ranges, based on consensus guidelines, within 60 minutes. The majority of patients did not require a dose adjustment to reach goal, and no rescue therapy was needed in any patient. Cardine IV maintained blood pressure control for 24 hours. Discontinuation of Cardine IV infusion is followed by a 50% offset of action in about 30 minutes. If treatment includes transfer to an oral antihypertensive agent other than oral nicardipine, initiate therapy upon discontinuation of Cardine IV premixed injection. If oral nicardipine is to be used, administer the first dose 1 hour prior to discontinuation of the infusion. For proven steady control of blood pressure in hypertensive emergencies, Cardine IV delivers rapid, precise control within minutes. Cardine IV increases cardiac output and has not been associated with coronary steal, bradycardia, or rebound hypertension. The pre-mixed ready formulation is immediately available at the point of care, which helps minimize medication admixture errors. The sealed product is stable for 24 months in its original packaging under appropriate storage conditions. Indication: Cardine IV, nicardipine hydrochloride pre-mixed injection, is indicated for the short-term treatment of hypertension when oral therapy is not feasible or not desirable. For prolonged control of blood pressure, transfer patients to oral medication as soon as their clinical condition permits. Important safety information. Cardine IV is contraindicated in patients with advanced aortic stenosis. Hypotension and reflex tachycardia may potentially occur during treatment with Cardine IV. Therefore, close monitoring of blood pressure and heart rate is required. If unacceptable hypotension or tachycardia occurs, the infusion should be discontinued. Slow titration of Cardine IV is recommended in patients with heart failure or significant left ventricular dysfunction, particularly in combination with a beta blocker. Close monitoring of response to Cardine IV is advised in patients with angina, heart failure, impaired hepatic function, or renal impairment. To reduce the possibility of venous thrombosis, phlebitis, local irritation, and extravasation, administer Cardine IV through large peripheral veins or central veins rather than arteries or small peripheral veins. If Cardine IV is administered in a peripheral vein, to minimize the risk of venous irritation, change the site of infusion every 12 hours. The most common adverse reactions, greater than 3%, are headache, nausea, vomiting, hypotension, and tachycardia. Please see full prescribing information. For more information about this important solution for hypertensive emergencies, visit CardineIV.com or call 888-466-6505.
Vasodilator case study number 1. You're transporting a 73-year-old man from Hospital A to Hospital B for cardiac workup after an episode of chest pain. Your patient has a history of hypertension, hypercholesterolemia, hyperlipidemia with a long history of smoking. Doctor's orders indicate maintaining a MAP of 70. Your patient is receiving 35 micrograms a minute of nitroglycerin. Your patient's vital signs are within normal limits. You begin to transport. 15 minutes into the transport, your patient experiences a drop in blood pressure from 132/60 to 90/48. According to the Vasodilator protocol, what should you do? You should temporarily stop the nitroglycerin. You should lay the patient flat, reassess the patient, consider a 250 milliliter fluid bolus. Vasodilator case study number 2. You're transporting a STEMI patient who is in need of an emergency PCI. The patient has a large coronary artery occlusion. The transferring facility has administered nitroglycerin at 10 mics per minute, heparin at 800 units per hour, and an integralin infusion at 2 mics per kilo per minute. The patient has the following vital signs. The heart rate is 56, the respiratory rate is 18, the blood pressure is 148/70. The patient begins to experience chest pain at a 4 that was relieved to a 0 at the sending facility. What should your actions be? Assess all the patient's vital signs and stability. Repeat the ECG. If the patient's vitals are stable, titrate the vasodilator per the physician's orders. If the physician's order is vague or it doesn't give instructions to titrate, consult Paramedic Protocol 4202 or contact Medical Command. This concludes the Vasodilator presentation.